appreciate them. The information is all on the alumni page. If you go onto the community setting of SUNY Adirondack, you'll find all the information you need. We want to especially thank Erica for coming and doing this. She's from, as you see, she's the Associate Director of Programs and Services for the Alzheimer's Association of Northeastern New York. There is a Facebook page for the nursing alumni. The alumni just started last year. I don't think SUNY did not have the alumni organization. And I really want to thank the foundation people, Adirondack Foundation, Jill, Rachel, she's outside. They've really helped me put this together with Trish. And sorry, Trish, if we have a joke, we call it Callie or Patricia. But we really appreciate it, and the people that are here that have come to the meetings, Kathy being one of them, thank you very much. We have a planning committee. We have a committee for history. There's a bookcase in the nursing department, so there are a lot of pictures up right now, and if you want to add anything to that, please bring them. Ideas for presentations, we plan on doing 2 a year. There'll be CEUs involved with that, and with that, I'm going to actually ask Trish to come up.
Well, there's some business that I have to do because we are able to provide these CEUs through Glens Falls Hospital, through the Massachusetts Nursing Association. There's some things that I have to read, and then you have to mark it down in your evaluation, or you'll get in big trouble. Glens Falls Hospital is an approved provider of continuing nursing education by the Massachusetts Association of Registered Nurses Incorporated, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Please note that we've stated there's no commercial support for this program, and the presenter has no conflicting interest declared. Successful completion of this event is attendance of the entire event and submission of completed evaluation tool. Please make sure you signed in. You'll receive a certificate from me when you hand in the evaluation at the end of the program. 1.5 contact hours will be awarded. I would also like to introduce, I'm sorry, I have to turn that off. It's a pleasure to introduce Erica Salamina, the Associate Director of Programs and Service, Community Outreach, Education, and Early Stage Initiatives with the Alzheimer's Association of Northern New York. We all know what an important topic this is. Those of us who work in the healthcare setting are faced with patients like this every day. She holds a Bachelor of Science in Sociology and Adulthood and Aging Studies. After 15 years caring for the elderly and patients with dementia and their Alzheimer's disease, 10 years in the nursing home, and then 5 years in an assisted living facility. She was able to move here, where she considers the best of both worlds, working both with patients and families and providing this kind of outreach and education. And that is Robin Jussi isn't here. She just stepped out shortly, but our nursing directors, our acting nursing director for education, Linda Antes from Glens Falls Hospital, and Robin Jussi, who just became our new nurse director for education, is going to join us as well. So without further ado, thank you very much.
Thank you. Okay, can everybody hear me okay? Sounds fine. All right. So we'll get right to it. My name is Erica. I'm with the Alzheimer's Association of Northeastern New York. For those of you that are unfamiliar with our services, our main office is in Albany, but we do cover 17 counties. So we go all the way north up to Plattsburgh and the Canadian border. We cover south down into Columbia and Greene counties, and we go out west into the Leatherstocking region. So it's a really large territory. We encourage nurses, anybody in the healthcare profession, to use our services. There's many that we offer, and we're going to go over them today. To get us all on the same page here, I realize you guys are all healthcare professionals, so you have a great basis of knowledge. I thought we would do just a quick review of some of the definitions. So today we'll provide a basic review of dementia and Alzheimer's. Still a lot of confusion for some reason about those two terms, and people use them kind of interchangeably when they're not the same thing. We'll provide an overview of staging and how it affects a person's communication and behavior. We'll provide an overview of nonverbal communication strategies, which is really important when you're working with your Alzheimer's patients. We'll provide an overview of something called the positive physical approach, and then also an understanding of care considerations in a hospital setting. Now, just to get me on the right page, these are nurses that are still working, some are working, some are not working. You have a couple students, okay. So the basis of this presentation is for best practices in a hospital setting, although any of those best practices can really be applied to any type of care setting, whether it's a long-term care facility, a home care setting, or any other type of care option that there is out there. So we'll get right to it. We're going to begin just by reviewing some of these definitions. So we've got this thing called normal aging memory. We all probably have it. I say sometimes that you don't even have to really be aging to have these challenges with your memory, depending on what's going on in your life and how stressed you are and everything that's on your plate. Sometimes your memory can be affected. As a person ages, though, just like your body, you slow down. It's harder for you to run, to jump, climb stairs. Things like that happen in our brain too. So there's a normal slowing down of your brain, of your ability to remember things. It doesn't indicate any type of a problem. It just may take a little bit longer to complete some of those things. And that's really normal age-related stuff, nothing to worry about. Then we've got this condition called MCI, which thankfully a lot more physicians are using now as sort of the pre-diagnosis before they go on and diagnose somebody with Alzheimer's disease. So this is mild cognitive impairment. The impairment is really mild. It's slightly noticeable to other people, and it's going to show up on a test, but the impairment that they have is not significant enough to really impact a person's life. So they're not getting lost. They're not making too bad, mistakes at work and things like that. They're not forgetting to take their medications. It shows up on a test, but it's really not that serious. Some people that have MCI, the diagnosis of MCI, will go on to develop Alzheimer's disease, and some will not. So there's really no rhyme or reason for that. People that do have MCI, though, they're a little bit more likely to develop Alzheimer's going forward. We've got the term dementia, which we know is kind of that umbrella term that describes the symptoms that occur when your brain is affected by a specific disease. So we know what those symptoms are: problems with memory, reasoning, judgment, problem solving, language abilities, all of those things. So that can be reversible. Thankfully, there are some reversible dementias out there, which are great, and we always make sure that doctors are really taking a hard look at all of those things that could possibly be affecting a person's cognition that might in fact be treatable. And then there are irreversible dementias. There's actually over 80 different types of dementia out there. Alzheimer's disease just happens to be the most common form of dementia, and it accounts for about 70% of all the cases of dementia. So if the doctors are not coming up with any other reason for why this person is having this cognitive problem, statistically speaking, it's likely that it is Alzheimer's disease. Just a little bit about the prevalence of Alzheimer's. So we know that 5.4 million Americans have this right now. It's a growing number. It's a growing problem. Really bad statistic up there, and this is something that's gotten much worse over the last several years. 1 out of 2 people over the age of 85 will develop Alzheimer's. So Kim and I, yesterday, we spent the last couple days in the high school, and they were really kind of startled with that statistic, because I said to them, if we were all 85 years old in this room right now, half of us would have Alzheimer's disease. Is that good? Not at all, no. And that's something that just keeps getting worse, because right now we don't have an appropriate treatment for this disease, and we're going to talk a little bit more about that. Every 67 seconds, somebody develops Alzheimer's, and the total cost is really high, $226 billion it's expected to cost us, with 153 of that expected to be Medicare and Medicaid money. So that's an awful lot of financial taxing on all of us. Just in New York State alone, we have about 380,000 people that have Alzheimer's disease. This number, in my opinion, is significantly low, because 380,000 is the number of Alzheimer's cases that we know about. There's so many more people that are not diagnosed, that live at home alone, where people are unaware of their symptoms and they don't go through the whole process of actually getting a diagnosis. So this is kind of a lowball number, and you can expect that to be higher. At least 30% will live in a long-term care facility. There's a lot that also live alone. And an individual with Alzheimer's disease costs New York State 19 times more than the average person on Medicaid. This is a really long disease. And that's one of the reasons, not all of the reason, but it's one of the reasons why this disease is so costly to care for a person. Can last really anywhere from 3 years. Oh, is that the light or is that my, okay, it's the light, okay. That's okay. I'm like, oh, it's dizzy out there. Okay. It can last anywhere from, 3 years, which is a really short case, to 23 years, which would be a long case. The average is anywhere between 10 or 12 years. That's usually what we see. People are living a lot longer now. One of the issues that we're seeing, which is making Alzheimer's disease go on for so long, is that we've got medications, we've got treatments, we've got fixes for a lot of the other problems that people have as they age. We don't have that fix for Alzheimer's disease yet, but we're working towards that. Just a little bit about the staging. So there's a couple different models that you might see out there. There's Reisberg's 7-stage model. We use that model sometimes. Most of the time with the teaching that the Alzheimer's Association does, we use a 3-stage model. So mild, moderate, and severe Alzheimer's disease would be the 3 stages. In the mild stage, inability to reliably make new memory. We know that's because usually with Alzheimer's, the hippocampus is the first part of the brain to be damaged. That's where all that recent and new memory is stored. So you might see some personality changes. You're going to see problems with their reasoning and their judgment. Their executive functioning and their ability to multitask and problem solve will be compromised very, very early on. And you'll see a loss of initiative in a person. Now, in the early stage of Alzheimer's, sometimes that loss of initiative is their own sort of method of self-preservation. They know, I'm not quite following along with the conversation, things aren't coming out of my mouth quite right, I'm not going to go to that function because I don't want people to know. As the disease progresses a little bit further, that loss of initiative really becomes sort of a motivation factor, and they lack kind of that overall motivation and ability to even organize their steps to be able to get up and go do something. So it kind of changes gears a little bit. In the moderate stage of the disease, we see a change in their ability to manage their ADLs. So early on, they can still do that. In the moderate stage, and this is really the stage where they spend the bulk of their time, you can expect 6 to 8 years even in this stage of the disease. ADLs become difficult without somebody there to support them. So they can still maybe shave, they can still do their grooming and their dressing, but they may need a person there for some support, maybe some verbal cueing, maybe to provide some setup of materials and things like that. With all of that support, which will gradually need to be increased as the person's disease progresses, they can still do those things. So it's really important, and we'll talk about that, really important to allow them to do those things and to make sure we give them the support that they need so they can still retain those abilities. We'll see some behavioral challenges pop up in the moderate stage of the disease. We all know what those behaviors are with Alzheimer's disease patients and other forms of dementia as well. Delusional thinking, paranoia, little agitation sometimes, aggression, verbal aggression or physical aggression, sometimes hallucinations, especially in other forms of dementia that's a little bit more prominent. So those can be very, very challenging for care staff in any type of care setting, and then for the family caregiver as well to have to deal with that in a home setting. We see more confusion, and then we see more communication difficulties. So in the early stage, trouble finding a word here and there. They may or may not be able to come up with it. By the middle stage, they're really losing a lot of their language skills, harder and harder to find the right word. They may be mixing words up. So, pointing to this, and instead of saying water, saying something like watch, because they both have similar beginning sounds. And by the time the severe stage happens, they have a total dependence on their caregivers. So even with support, verbal cueing, setup, hand-holding, things like that, they're not able to participate in their personal care. At this point, their short-term memory and their long-term memory are both affected, and there's minimal verbalization. I was telling the students this, and I think that they got a kick out of this week. So both of my grandmothers passed away with Alzheimer's disease. My one grandmother, she kind of progressed very rapidly through it. It was about 6 years, and even to this day, we're still not certain that she had Alzheimer's type dementia. She may have had something else. My other grandmother was basically, just a classic textbook case. Everything I described happened in just that order. She had it for about 14 years. When she was born in Italy, so Italian was the first language that she spoke. She learned English much later on in life. When it came time with her Alzheimer's disease and it had progressed and she kind of stopped speaking, she lost the ability to speak English words first, okay? Because she had learned that more recently in her life. The last words that she spoke were in Italian. She was able to speak that for a few more years into the disease when she could no longer speak English. Italian words were the last words that she spoke, and probably for about the last 4 years or so of her illness, she didn't speak at all, which was not, not very characteristic of her, because she was a talker, as most people are in my family anyway. All right, so just a little bit about the pathology and causes. I'm sure you guys know this. We know that there's 2 culprits that we have found to be the case in Alzheimer's disease. 2 different proteins. So beta amyloid, which causes a substance called plaques, and an accumulation of a protein called tau, which causes a substance called tangles. Now what we don't know, while we know plaques and tangles cause Alzheimer's disease, we don't know what causes the plaques and tangles. So we really still have a lot of work to do on that front, but we're getting further. Very simply, the plaques and tangles attach to the brain cells, they kill the brain cells, and the brain cells die off. They're eliminated through the body just like any other type of waste would be. My executive director, she worked at Albany Medical Center for many years, and she had the privilege of observing an autopsy. They were actually autopsying the brains of 2 people that had passed away. So the first brain was of a man. He was about 85 years old. He had Alzheimer's disease for about 12 years, and he had ultimately passed from Alzheimer's disease. The other brain that they looked at was the brain of a newborn baby. This baby was born prematurely, and the brain of that baby had not yet been fully developed. Okay, so the baby died at birth. So we've got this man who has lived a full life, 85 years, and this baby over here that died at birth who had a brain that wasn't yet fully developed. Reality tells us, and just being realistic about this whole thing, this should be the bigger brain. But what happens with Alzheimer's disease, this gentleman's brain had shrunk so much in size and volume and weight, because the plaques and the tangles had attached to those cells, killed the brain cells, that this baby with the brain that was not yet fully developed weighed 3 times as much as this gentleman's over here. So it's really kind of fascinating when you think about it. And Kim and I, as I said, we just did some teaching in the high school this week that was really fun. They were kind of astounded by that, and it really helps us, with your caregivers and your staff that are working underneath you, we can't see what's going on in a person's brain. They're not acting right, but you can't put a look on it. If you can picture that scenario that I just told you, parts of their brain are just no longer there. It really shrinks that much in size, so it helps people understand it a little bit more, and sometimes makes them care for the person with a little bit more, dignity and understanding as they would have. So keep that in mind. As I said, we know that the cause is plaques and tangles, but we don't know yet what causes the plaques and tangles. Experts say that there's probably multiple factors involved, and we do know a little bit more about the risk factors now. So here's just it's not a great picture, but it's a picture of a large brain, healthy cells, looking pretty good there. And here's the brain of a person with Alzheimer's disease. So all of that dark area is where the plaque buildup was, killed the cells, and the brain actually shrunk that much in size. So it really looks very different. Okay. So treatment options, I could have been standing here several years ago telling you the exact same thing, because we are just not progressing fast enough in the area of treatment options. Still, the only medications that we have available are cholinesterase inhibitors, so Aricept, the Exelon patch, we know about those. Most of our patients are on those. And then Namenda, which is a little bit different. It regulates the glutamate in the brain. There's also medications that we use to help with some of the symptoms of Alzheimer's disease. So when those behavioral challenges pop up, some of the anxiety type issues, sometimes we use antidepressants. We know that depression goes hand in hand with Alzheimer's disease. About 70% of people with Alzheimer's are depressed. So sometimes that's a factor there. Sometimes we use antipsychotics, anti-anxiety type medications, just to get a handle on some of those behaviors. Medications, you guys know, always used as a last resort. We use environmental modifications, compensatory techniques. Early on in the disease process, we teach a class, it's called EASE, and it's an 8-week partnered learning education program for people in the early stage of Alzheimer's and their care partners. We do a lot of these compensatory technique teaching in this class. Early on in the disease process, they still have the ability to learn some strategy, to simplify things, to put some systems in place to help them remember and function in their day-to-day life a little bit better. And that's what we mean by compensatory strategies. We offer lots of support and education for patients and their caregivers. In your folders, this is not in your PowerPoint presentation, but in your folders I gave you a couple things that you guys, especially in your profession, might be interested in. So one of the reasons why we don't have a cure for Alzheimer's disease right now is that historically the clinical trials that we have surrounding these new drugs that we want to get to market have not had enough people to really run and have a good impact. So that's our first problem. Very, very low percentage rate in clinical trials. Our other problem is that there's a general misunderstanding out there about clinical trials. So what people don't realize is that we need normal controls, just like yourself, just like myself, to participate in the clinical trials, or the trials do not run. So we need people without cognitive impairment to be the control in the study so that these medications can get to market. So that's a second reason. Another reason is that people have a sort of a misunderstanding about what clinical trials are. You think of that, and automatically you think of medications. That's what we're doing. But with Alzheimer's disease specifically, there's a lot of trials out there that don't have anything to do with medication. There are studies on exercise, so we're studying the effect of exercise and how that affects your cognition. So there was a study not too long ago. They did some cognitive testing. They had the person participate in 30 to 45 minutes of aerobic exercise, and then they did the cognitive testing again. And then there was also some controls in that study that didn't do any type of cognitive testing. There are studies out there that are studying other types of activities, light therapy, things like that. There are very simple biomarker studies out there. So you guys know, because you're nurses, we can take a vial of blood and we can tell if somebody has diabetes, right? We want to be able to do the same exact thing for the Alzheimer's disease patient. We want to take their blood, study it, compare it to somebody that doesn't have any of those symptoms, and see what's different, and see if one day we can't find a biomarker that would indicate that this person is going to get Alzheimer's disease or definitively has Alzheimer's disease, okay? So there's lots of ways that trials can be helpful. I gave you just a little brochure about that. You can keep it for yourself. You can pass it along. I also gave you a trial match postcard. If you guys, and I brought it here because I thought this would be a great audience to talk about this too. If you're interested in learning more about clinical trials and how you might be able to help, fill out this postcard, leave it for me, I'll send it back for you. It doesn't commit you to anything. All it does is say, you know what, I'll hear some more information. I did this, I get emails, I've participated in a couple things. So I participated in one real easy one, little brain game thing that I did on my phone on my lunch break. And that was the clinical trial that I participated in. I've given a couple vials of my blood. I don't miss it. It's kind of what I can do. I have two grandmothers that both had Alzheimer's disease, and I'm worried about my future and the future of my mother. So this is kind of the way I'm helping. So if you'd like information about this, fill out this card. They'll get you more information. It doesn't, again, commit you to any type of clinical trial. It's really great to know, though. All right. So moving on, we know that communication is a big problem with Alzheimer's disease and dementia patients. It starts early on in the disease process, and it just gets worse and worse progressively over the course of the disease. So here are some of the major challenges that occur. Obviously, word finding difficulty is a big one. Repetition, we know that they repeat things because the information that they're repeating, many times the answers go right into their hippocampus, and with that being broken, so to speak, there's no place to store that recent information, so they repeat things. They may revert to their native language. That's definitely a communication challenge, and it was with my grandmother, because at the facility that she was at, nobody spoke Italian, so it was kind of a big deal. There's a loss of ability to speak in clear sentences. Sometimes they jumble up their words. Sometimes they say words that don't make any sense. Sometimes they just make them up. And there's a loss of ability to understand and use words completely. Lots of reasons why these changes occur. I always like to put this picture up because this kind of highlights where the problems can be in the brain. So if you were to ask one of your patients, what do you want for lunch today? and they kind of gave you a blank stare, they didn't answer you, they're just kind of looking at you, they may not be able to understand through verbalization anymore. But if you were to write on a piece of paper, what do you want for lunch today? They may very well be able to answer you, because the part of the brain that controls understanding through reading and comprehension may not yet be affected. So this is huge. When we go out into care settings and people say, oh, they just don't answer me. Well, we need to really, as caregivers, get away from thinking that words are the only way to communicate, because that's just not the case. So think of this picture, depending on which part of the brain is affected, you're going to want to adapt your communication technique to meet where their strengths still are, okay? So this is kind of an interesting one too. We've done a lot of studies on this, and before I know that the percentages are up there. When we go out into care facilities, we have a very hard time with that frontline staff getting this across to them. So I do a little experiment, and I walk in and I say, hey guys, my name is Erica, and I'm so excited to be here today. I couldn't wait, flew down the Northway, almost got a speeding ticket so I could get here on time and start this class. And then I asked them, how do you think I felt about coming here today? What do you guys think? How do you think I felt? Pretty excited, right? So then I say, hey guys, my name is Erica. I was so excited to come here today. Flew down the Northway, almost got a speeding ticket. Couldn't wait to get here, so here I am. Now how do you think I feel? Not excited at all, right? Sometimes this is the only little thing. I'm not a good actor. I never claimed that I was. But sometimes this is the only little experiment that will get it through to the staff that your words don't account for hardly any of the message, because the words that I just said were basically the exact same. So all of this other stuff is much more important, and we've done studies. That's just my little example, but we've done studies to back this stuff up. So in terms of what matters more when you're talking to a person that's got Alzheimer's or dementia, body language is a big thing. Even though they may not be verbally understanding you or vice versa, they can read your body language. If you're in a funky mood, they know that, okay? They can feel that coming. The pitch, the tone of your voice, your volume, eye contact, are you looking at them? Do you seem interested? All of this stuff is much, much more important when you're talking to your patients with Alzheimer's disease. So keep that in mind. All right. So just some communication strategies. We always want to utilize nonverbal communication. Remember that scenario. Words account for the least of the message coming across. Always speak to the person as an adult. They may be doing, childlike things. I have a lot of caregivers that say, I don't know, just my wife, she's acting infantile, and they use these words. They're still an adult, okay? So we've got to keep our care always dignified that we're giving them. Include the person in conversations. In the healthcare setting, I can't tell you how often I go in and I hear, maybe a CNA and a nurse, and they're talking about Mr. Smith's behaviors or Mr. Smith's bowel movements or something inappropriate, and poor Mr. Smith is right there. We really don't know how much of the conversation they're picking up. Even if they're picking up none of it, it's still not appropriate. So include them in conversations that they need to be included in. If it's an inappropriate conversation, don't have it in front of other people, but then don't have it in front of them as well. Keep that respect there. We always want to put some emphasis on recognition and not on recall. So I would have staff and they would say, oh, they don't even remember my name. But they might remember your friendly face coming down the hall, and that's much, much more important. People think, oh gosh, they've got Alzheimer's. I don't know what they feel. They probably, they don't know me. I don't know if I make them happy anymore. But even if they can't verbally express how they're feeling at that moment, you're making them angry. You're making them happy. They're thrilled to see you. They didn't want to see you today. They can still feel those feelings. They just might not be able to verbally communicate that. Feelings are still intact. Okay, so don't worry about the facts, that all the words are right, that all of the facts of the situation are correct. If they recognize you, if there's certain pieces of the situation that they're trying to describe and they're sort of getting it right, that's good enough. And always speak positively and avoid don'ts. So just like any of you guys that are mothers, Very easy to get into a trap. Don't go there, don't do that, don't touch that, don't go in that person's room, don't touch that, don't eat that. Really easy to have your whole day be consumed with this negativeness. Anytime that you can, you really have to work at this. This isn't a natural thing. Turn it into a positive. How about we do this instead? Would you like this to eat instead of that? Let's go here instead of the don't, no, no. Okay, that kind of weighs on you as a caregiver, definitely, but also on the person that's got the Alzheimer's. Okay, so more strategies. Always identify yourself. Even if they knew you an hour ago, doesn't necessarily mean that they know who you are now. If you're a nurse and you're coming at them with medication or a syringe or something like that, really important for them to know that you're the nurse and you're trying to provide care. You're not a bad person coming at them with something scary in your hand, okay? Call them by their preferred name. So I've spent 15 years, caring for elderly people. There's many people that will get offended if you don't call them by their preferred name. And for a woman with Alzheimer's disease, although she's 80, 85 years old right now, she may not be living at that time in her life. She may be living at the time where she was a teacher. And they called her Mrs. Smith, not Laura. Okay, so we want to know what that preferred name is. Not only that, where they are in their disease process. Does she still think she's a teacher? Because it would be respectful then for us to call her Mrs. Smith. Use short sentences if you can, okay? Wait for a response. So you and I can have a conversation. 1, 2 seconds go by, we can kind of go back and forth and talk to each other. It's not uncommon for somebody with Alzheimer's disease to take 10 seconds, 20 seconds, even 30 seconds to process what you just said to them and then give you an answer. Sometimes they're not going to give you an answer, right? Do we find ourselves repeating ourselves when we're talking to our patients? So one of the things that we normally do in society, which is the exact opposite of what I want you guys to do, is we rephrase things, we paraphrase things. So we may say, Mrs. Smith, how are you feeling today? We're waiting for that extra response time. Mrs. Smith is still not looking like she's processing anything. So I might think to myself, geez, she didn't get it that way. Let me try a different way. Mrs. Smith, do you feel good today? Do you still have that headache like you had yesterday? With a person that has Alzheimer's disease, that's the exact opposite of what you want to do. At least for the second time that you're repeating yourself, you want to repeat the exact same way. So it's further getting the question and the message, just reiterating that and giving them that extra time to respond. Now, if after 2 times you've repeated the question the exact same way, same words, and you're still not getting a response, try something different, but at least the first 2 times. And the reason why we say that is very simple. They may be still processing that first question. They may be just about to answer or just figuring it out. Now you've asked them a completely different question. Now they're probably not going to answer any of your questions, right? Because you just confused them more. So keep that in mind. Avoid confusing expressions and vague words. Confusing expressions, I have had this happen. The term, jump into bed, jump in the shower. Actually had a resident try to jump into bed because that's what I told them to do, and they landed on the floor. So that was not a good thing. People with Alzheimer's disease can tend to take things very, very literally, okay? So keep that in mind. Avoid quizzing them. It kills me when I see family members come in, they want to visit with mom and dad, and they say, well, what'd you do today? Did you go to the activity? What was the activity? What'd you have for lunch today? Was it good? That's all short-term memory stuff. They're not going to remember any of that. Chances are they're going to get frustrated with that interaction, and then the family member is going to leave thinking, I don't know why I come anymore because our interactions are just no good. Lots of other ways that you can teach your family members to have meaningful interactions. Give simple examples. So whenever you can, keep it simple. No need to say, you know what, Mrs. Smith, we got to get up, we got to hurry up today. You have a podiatry appointment and we've got to be up by 9:20, otherwise you're going to miss that bus. And if you miss that bus, we're going to have to wait for the next bus to come around, then you're going to miss the appointment. Way too much information, okay? Mrs. Smith, you have to get up right now, you've got a podiatry appointment. Leave it at that. They don't need to know all of those details. Those are for you to know and sort of help them along. And of course, don't argue. We know they spend the bulk of the time in the moderate stage of the disease, and that's the stage where we see this delusional thinking pop up. So if they think that just because it's a sunny day out, the sun is shining, and they're going to go out for a walk in their shorts and t-shirt, but in reality, it's January and below 0, you don't want to argue with them and say, you know what, it's January, what are you thinking? You can't go out like that. You need to distract them and redirect them in a different way. Don't argue with them. Big things that we see, paranoia, that's a big, big problem with these people. You know, if I think maybe you stole my pocketbook because you sort of look like you got the glasses, and I think, pretty sure it was the one with the glasses that took it, if I think that, and I have Alzheimer's disease, I 300% believe it to be true. Not one word in this room any of you guys can say to convince me that she didn't take it. She may have not even been in the state when my pocketbook went missing, but I believe it. This is my reality, not yours. So a better way to answer her might be to say something like, you know what, Erica, I know your pocketbook is missing. If she took it, we'll get to the bottom of it. If not, we'll figure out who did, and I'll help you find it. So you've gotten into my world, you're joining my reality, you're validating my feelings, so I feel like I can trust you a little bit because you're hearing me, and then we're going from there. So it went from a possibly, you know, contentious situation where we were arguing to now, okay, I can trust this one. Okay, so that makes it a little bit easier. And then in the caregiving setting, we have this thing called the positive physical approach. So oftentimes when I, you know, do teaching in a nursing home, I see these things and I sometimes cringe. You've got a patient that's got dementia and they're in a wheelchair and the staff will come right up behind them and start pushing them. Well, if that was me sitting in that wheelchair and I all of a sudden started moving out of nowhere, I would start swinging and kicking, or even worse, I would put my feet down and I could potentially roll right out of that wheelchair. So to avoid stuff like that, we want to use this positive physical approach in almost all the interactions that you have with your patients that have Alzheimer's disease. So always approach them. I see there's a typo, I apologize. Always approach them from the front. Always go slow. It doesn't matter that, you know, they're just number one in the next 20 patients that you're giving meds to that day. They don't understand that, okay? So go slow, even if you're in a hurry. If you're coming at them full speed, they may not exactly know who you are, and that could be kind of intimidating. Get to the side, okay? That's a better way to do it. Get low. We see this a lot of times now in restaurants. Anybody ever experience a server who will get down to eye level? I like it in the caregiving world. I don't think I really like it in the restaurant world. But in any case, get low. Standing above somebody like that can be intimidating as well, so we don't want to do that. Offer your hand. That's just a real general thing that you can do. Some people will take your hand, and if they take your hand, you now know that you can use some gentle touch in your interaction with them. And that touch can be used to calm them down, to get them to do what you want. You can use touch in a lot of ways. If they don't take your hand, that might be an indication that this person is not a touchy type person. So you shouldn't touch them, okay? Use the person's preferred name. We talked about that, and wait for a response. So think of this positive physical approach. Share it with your staff members. It goes a long way. All right. So also you want to eliminate distractions. We want them to be able to answer our questions and to do what we need them to do, whether it to be get dressed, have them take their medications. Many times they can't do that if there's a lot of competing noises and distractions going on. So if there's a TV on, a radio on, too many people are talking, they may not do what you tell them to do, and it's not because they don't want to, it's because they can't really focus on you. There's too much. So eliminate the distractions if you can. In a hospital setting, sometimes it's a little bit difficult to eliminate the distractions, and you just have to kind of work around that. Face them when you speak. Always alert them of your presence. So if there was a door behind me, and I have Alzheimer's disease, I can understand somewhat the stuff that happens in front of me, because I can see it, okay? All of this space back here, it's kind of abstract space. People with Alzheimer's disease have a really difficult time understanding abstract things. So days of the week, time, you know, concepts of time, space when they can't see things, very, very difficult. So if I was to come in the door and all of a sudden appear, that might startle them. So alert them of your presence. Tell them that you're coming, especially if you can't make eye contact with them immediately. And speak slowly and clearly, and then also maintain a normal conversation style. So although they may not get some of the words right, the facts right in the conversation, they still, for the most part, are able to remember the back and forth style of a conversation. So keep it as normal as you can, you know, for as long as you can. Okay. All right, so before we move on from communication, communication. Does anybody have any questions about that? Or, questions about the settings that you work in or with your staff members? Does this communication stuff make sense? We really, yes.
I'm just curious about to what extent you entered their reality in terms of, I don't know, if they think the bus is coming outside in the hallway, or that their uncle is in the room. How far do you take that?
So, in my opinion, you take it all the way unless there is a safety concern. So if this person is, thinks the bus is coming, they're a danger, they don't walk steady, they're, super confused and they're about to hightail it out the door, that's a safety concern, and at that point, you may want to try, orienting them a little bit back to reality. That's not usually going to work, you know what I mean? So that's why I say only try to do that if safety is a concern. Otherwise, you should be joining their reality all of the time. And we want to do that because they have no ability to join your reality, our reality here, okay? No ability. You are the only person that can adapt, okay? This whole, idea of reality orientation versus validation, it's an age-old debate. Reality orientation is really an old school way of caring for people with Alzheimer's disease. Many times they can't be oriented back into today's reality because it's not theirs, okay? So we have to adapt. Validation is much better. Couple examples, so we've had people, for example, very kind of anxious, worried, wandering around looking for a husband. Where's my husband? Where's my husband? Very, visibly upset. And the husband has passed away, okay? You and I know that. She doesn't remember that. Reality orientation would be to snap her back into reality and say, your husband died, don't you remember? We're not going to look for him now because he's already passed on. You were there. You were at the service. Sometimes that can be more cruel. This happened with my own grandmother. I mean, my grandfather died many years before her. She was in the moderate stage of Alzheimer's disease when he died. And until we could get all on the same page for those first couple days, it's really challenging. You don't know what to do. So we had to tell her multiple times, he died, he died, he died. Each time, it was like she was hearing it for the first time, and she would grieve and weep and sob. And it really was, we finally said, this is kind of cruel. We don't want to do this anymore. So, we told her a story that made sense to her. We said, you know what? He's not here right now. He's in rehab, which he had been, thankfully, before he died. We're going to, we'll tell him that you miss him. We're going to be seeing him. He'll be back at some point soon. And that kind of appeased her for a little bit. And then we could get her talking into, tell me again how you and Grandpa met. Let's look at some pictures of him. You know what I mean? So you validate their feelings. In those situations where you've got patients that are really anxious because they've got to go pick up the kids, they've got to, the kids coming off the bus, their kids are full-grown kids, you want to think about the underlying emotion. So if you think you're going to be late, you're picking up your kids, you're feeling frantic. We've all been there before, right? You've got to get there. You want to respond to that versus the fact, and the fact of the situation is that the kids are grown, they're picking up their own kids right now, probably. So you want to say, you know what? Don't worry about that. It's all taken care of. The neighbor's picking the kids up today and taking them to swimming or something like that. Some people have a hard time with this because they say, this is lying. I understand it's against some people's religion, but when you're dealing, with an Alzheimer's disease patient, this is probably the way that's going to cause them the least amount of stress. We want them to be content. You know what I mean? And it's also the way that's going to cause the caregiver the least amount of stress, right? So it's a good way to go. Yes.
I just wanted to comment. I recently relocated to New York, South Carolina.
Okay.
I was down in South Carolina. I had the opportunity to work as a hospice nurse for 5 months. I wish that this presentation was provided to myself and my other colleagues when we started. It was a new company. It was not. So I just relied on my old nursing skills. And I'll tell you, that therapeutic touch, that getting down to their level, speaking calmly, tremendous. What a difference, and it was wonderful with that. Because I worked, most of my patients, I had a 22-patient caseload, and most of them were in the moderate stage, but at varying degrees
Sure.
of moderate stage.
Yep.
But that therapeutic touch and that soft, calm voice and
Yep.
approaching it from the front, non-licensed folks come in, even some of the licensed folks out there, and they just come in like
Barreling,
hell,
yep.
and then the patients start fighting, and then they want to give them more medication. It's like, whoa.
Yeah, it's a big
So,
snowball, you
Yeah,
know?
it really is.
The challenge that we have with this is that, taking care of a person with Alzheimer's disease, it takes more time. And it takes more time because you want to do it right. So when you have a patient that's looking for, her dead husband, the quicker response is to say, he died 3 years ago. It's much more difficult, and it takes a lot more time to say, think of something. He's not here right now. I believe that he works late on Tuesdays. He'll be here. Tell me about him. That's a harder response, and you have to learn that response. You've got to get your staff to learn that response. You can really have some fun with kind of, working ideas off of each other, but this is the best way to do it. There's a lot of science behind it. It makes more sense. So thank you for that. All right, any other questions or comments about the communication stuff? Big piece of it with these guys. Yes.
We had this patient, and he always did whatever I asked. He wouldn't do it for anybody else. My day off, wouldn't take his pills, wouldn't do anything. And even if I went in and it was another nurse, I'd go in and made eye contact and touch his hand, and I said, Pete, it's Teresa. Can you take your pills for me? He'd do everything. His wife realized that I was the only one who I never raised my voice to him, and I didn't yell at him.
Yep.
And she said she noticed that.
Yep.
So she said it's very hard, everybody raises their voice. He wouldn't do anything even for her. So she said I was always calm, and I waited, and he did whatever I asked.
Yeah. So that goes back to the feeling thing. So he may not know you as Teresa or recognize, know exactly why you're here, remember your name, but he remembers the feeling that he gets when you're around him, which is calm, okay, I trust her, things are okay with her, and it's much easier, You've got to build that. They still can feel feelings, okay? So really good point there. Yeah, you're doing it right. All right. So moving on a little bit to some best practices, again, in a hospital setting, but also in a lot of other healthcare settings. We know that many people with Alzheimer's disease require a hospitalization at some point. It's almost inevitable throughout the course of the disease. What we don't think about a lot is that there's a lot of adverse health events that people with dementia experience during a hospitalization. These are really astounding when you think about this, and we've researched this stuff. They're 3 to 6 times more likely to develop delirium. Makes perfect sense to me, okay? 1 to 6 to 5 times more likely to fall. We know that at least 50% of the falls in a hospital setting are from some sort of dementia, okay? 5 times more likely to develop new urinary incontinence, and 6 times more likely to develop fecal incontinence. They can't always find the bathroom. They're in a new surrounding that's not familiar to them. There's reasons why this stuff happens. 5 times more likely to develop pressure sores. They're not saying, okay, I'm a little bit sore right here, I think I should switch positions. That's not happening with these guys. More likely to have untreated pain because they're not the best historians. They can't always tell you about their pain. 2 to 4 times more likely to lose the ability to perform their ADLs during a hospital stay, and less likely to return to their functional abilities. And we've all seen this happen. 2 to 4 times more likely to be discharged directly to a nursing home, and 3 to 7 times more likely to be living in a nursing home 3 months after discharge. Now, sometimes that's what we want. These people live in a nursing home, and that's kind of where they need to be. Other times, we don't want that. We want them to go maybe for a short-term rehab stay, and a lot of times with dementia patients, they just can't do that. So those are some really kind of startling statistics. So we know when somebody goes into a hospital setting, it doesn't matter if you have dementia or not, it can be challenging for all of us. Anybody can kind of become disoriented, but for people with Alzheimer's disease, they may not even recognize that they're in the hospital setting, and that presents a whole different challenge. Not only for them, it presents a lot of challenges for the care partners and also for the staff there, so it's a big thing. So we've got the unfamiliar environment. We know it causes an increased risk for wandering. They're always seeking the familiar. They're seeking something that they know. That's why they want to wander. Sometimes it puts them at a higher risk for elopement, definitely a higher risk for falls, confusion, and behavioral problems. There's also this thing that we've learned about called the progressively lowered stress threshold, PLST. And this is the idea that people with dementia have an impaired ability to deal with stressors. So you think about going into a hospital setting, whether it's you, me, somebody without dementia, whatever. That's challenging enough. You have to be able to handle the stresses of a hospital, and there's a lot going on there. People with Alzheimer's disease have a lower stress threshold. That's a tongue twister. So that, has a lot of implications in the caregiving. We know that in a hospital setting, a lot of times the staff just don't have time to provide. It's a very task-oriented setting. You're trying to get them here, fix the problem, and get them out and on their way. So time is a big problem. And also with the hospital staff, sometimes knowledge is a problem as well. This stuff that we're learning about Alzheimer's disease, it may be stuff that, it may be a nice reminder to you guys. Probably you know a lot of this. A lot of the care staff don't know this stuff. They haven't learned it yet. They may deal with Alzheimer's patients every day, but they don't know the best practices. So we always want to be teaching that type of stuff. So before we move on here, we're going to take a look at some specific areas in the care setting, again, hospital setting, home care setting, wherever, and see the things that you might need to think about a little bit differently with your Alzheimer's or dementia patient and how you can make the care a little bit better. So we're going to start with safety because that has an overall effect on a lot of things. So we know it's a priority for all hospital patients, and we know that caring for a patient with dementia can take more time. But if you adapt your care techniques to improve the safety of a person, your outcomes are going to be greatly improved. So some best practices: definitely slow down with that person. We don't want to agitate them. Keep them calm, okay? So using the stuff that we talked about in the last few slides, the positive physical approach, some of those communication strategies are going to help those things. Address the causes of agitation. Many times when a patient is agitated, we are the cause. That's a rough, thing to, we don't want to say that we're doing it, but sometimes we are. The environment is too fast-paced. We're not approaching them correctly. We're not giving them the support that they need. You want to prevent wandering and elopements with supervision, activity, distraction if possible. You want to accommodate the need to explore and to venture. Sometimes this means you need to engage the family and say, you know what, we understand your loved one's got to get up, they want to move around, but we don't have the staff to supervise them. Yet allowing them to move around and to get some of that, energy burned off and explore may prevent a wandering episode or an elopement episode. So it's really important that we allow those things to happen. I realize it's not, always realistic to have the hospital staff be the person that takes them for a walk to burn off energy. There might be a volunteer. I don't know if some of the hospitals around here, if they do have, volunteers, or engage the family. We want to try to prevent and reduce falls, promote their function, and of course address their medical needs. When it comes to wandering and elopement, and we're considering this a dangerous behavior, because a hospital setting is kind of unique and new, we want to think about why they're doing so. So wandering is a behavior, and oftentimes there's an unmet need there that we're just not meeting this person's need, and they feel the need to do something, and that may present itself as they need to get up and they need to go, because they've got to get whatever this is handled. They might need to move, they might need to stretch. Many of you guys, as we're sitting here, and as we approach the hour mark, you're going to have to adjust. You might need to get up and stretch your legs. People with Alzheimer's disease need to do that too. They just can't do it in a reasonable fashion like we can. They might want to find something familiar, so they're in that hospital setting. Things are confusing. They may not recognize anything. They're looking for the familiarity. They're looking for something that's going to reassure them and make them feel safe. That could trigger a wandering episode. Many times, wandering incidents as well as falls are around the need to use the bathroom, right? So we know incontinence is a big issue. We've got to meet that need. You also want to consider the visual triggers. And I call these things travel triggers. So in a person's home, or even in a long-term care type setting, there's an easy fix about this. So we all know you're going out of your door at home, you're going to work or going out for the day. What are the things that you grab before you go? What are the things you need with you? Keys, purse, coat, yep. These are travel triggers. So those are the things that could trigger a person to say, you know what, oh, there's my keys, I've got to go. not necessarily know where they're going. Oh, there's my shoes, I'm gonna be on my way now. They're not reasonable enough, they've lost the ability to reason and they've lost their judgment, so they're not gonna do that appropriately, but the trigger is there to make them wanna go. So sometimes stopping a wandering or an elopement incident is as simple as hiding those things or just putting them out of sight. I used to have a woman, and this was in a nursing home setting, she used to try to wander every day around 3 o'clock. One of those ladies who thought she had to go pick up her kids, and kids are grown, they have their own kids. And the trigger was the clock. She could still tell time. She looked up at the clock, nope, it's 3 o'clock, gotta go. And out, she would go. All we had to do was move the clock to a part of the floor that she didn't go to, she never wandered again. Now, they're not all that easy, you know. We didn't take the clock away, permanently, and we certainly would not tell her what time it was if she asked, but it was just that visual trigger that she saw every single day that was making her go. Easy fix to that one. So some things that you can do, of course, think about those unmet needs. Think about providing a safe way for them to wander, so companion, volunteer, utilize the family, but find out about their patterns. Ask the caregiver. Does this person usually go out for a walk every day? I know that if this was my mom, she walks about 5 miles every day, we would be in trouble because she walks and she's gonna walk, and I know about the time that she does it, so we may be able to get ahead of that. Keep the suitcases, street shoes, coats, out of sight access. Those are those travel triggers that I was talking about. Ask family to bring something comforting in from home. So again, they're looking for the familiarity, they're looking for the comfort. Bring something in. A picture, a stuffed animal, a favorite blanket, whatever. It's different for everyone. If possible, consider a room close to the nurse's station. If that's not possible, maybe it's a room away from the exits, so they're not looking at the door out. That might be taking away that trigger. You can always utilize adaptive equipment and safety technology, wander guards, bed alarms, chair alarms. I find just from working in the care setting for so many years, we really tune out a lot of the beeps and the buzzing and those things that happen. So you need to utilize those things sparingly. So we're still sort of sensitized to, okay, that person's wander guard is going off, that means that they're wandering, and we actually hear it. So you can use those things. Sometimes they work, sometimes they don't. A lot of it with, preventing behaviors, preventing wandering, is talking to the family and learning about this person, their patterns, and creating some sort of an individualized plan. We can't do cookie cutter plans. They don't work for everyone. All right. You can also use distractions, music, snacks, simple activity. Talk to the person. Maybe there is a volunteer in the hospital that can just sit with the person for a little bit during a time, hold their hand, assess the need for a sitter or a companion. Even in nursing homes, at some point, we've had to talk to families before and say, you know what, the staff can't manage this. Until this resolves, we need to bring in a companion for them to keep them safe. Unless the family wants to provide that service themselves, and sometimes they will. There's some safety services out there. We have a medical or safe return program. It's not a technological program. It's a pendant that a person wears. If they should wander off and somebody finds them, we've got their information stored if a person that finds them calls the 800 number. We've also got some web-based tracking programs. There's lots of those out there. So in the area of pain, when we think about pain, a lot of times we think about physical pain. But there's a lot of emotional pain. I told you guys that with Alzheimer's disease, depression is very likely. 70% of the time, the person is also depressed. So that's emotional pain, the spiritual pain. So we've got to look at those things as well. First thing you need to do is understand the nonverbal communication as an expression of pain. So they're not going to come out and say, hey, Nurse Sue, I'm in a lot of pain today. Do you have any extra pain meds for me? Probably not going to happen. You've got to use that nonverbal decoding of their message. What's their face look like? Are they moaning? Are they making noise? Are they extra agitated today? Are they refusing care? Time and time again, I've seen a person refuse care because it was too painful for them. Maybe it was, giving the caregiver a problem during bathing or giving the caregiver a problem during dressing. Too painful for them to have, full range of motion and lift their arms to the extent that they need to lift. So think about that stuff. Pain, there's lots, and I didn't even list them on here because there are so many different assessing tools that are created to assess pain in the patient with dementia. Use one of those. I mean, that's what they're there for. Involve the care partner, certainly, in your assessment. Is this a change in behavior for the person? We need to know that. Or is this just their normal, how they act? What methods did you use at home to reduce the pain? The family might have the answer to the question that you've been working on all day. We just need to ask that question. And sometimes you need to make a referral to a pain specialist, to pastoral care, again, speaking to that emotional pain, sometimes even to hospice and palliative care. Sometimes that indicates it's time to look for stuff like that. In the area of prevention, some best practices, obviously turning, making sure they're bathed, dressed appropriately, incontinence care is given, which can be a challenge sometimes. Apologize in advance for activities causing pain. Sometimes it's just that little extra step that we take in terms of communicating with them that makes the interaction a little bit better. Offer reassurance, many times that's what they're looking for. Warn them before moving, just like we want to tell them who we are, why we're there, and what we're going to do. We want to warn them, okay? And certainly report pain. You can also do comfort measures and distractions, so activities, conversation, music, massage, warm washcloths, offer pillows, snacks, drinks of water, anything that's really going to make that person more comfortable. Those are all good things to do. All right, so this has probably happened to everybody in the room. You go into the hospital for something, a procedure, a broken leg, anything, and they put an IV in you all the time, right? So we know that medical lines are a part of hospitalization, and there's lots of different types of lines. You guys know that. The person with dementia most likely does not understand the need for the line. So you've got a challenge right out of the gate there with the line. They may not be willing, whether it's knowingly or unknowingly, they may not be willing to tolerate the discomfort that the line is causing. So it's important to assess the necessity, if it's truly necessary. So you really have to, spend a lot of time here, not on that line, but on thinking, you know what, do we really need this line? How crucial is this line to this person's health, their well-being, the reason that they're in there for? If it's not necessary, let's not do it with these patients. If it's truly necessary, what can be done to make the patient more comfortable? So best thing that you can do, obviously with the goal in mind that you want to reduce the number of lines as quickly as possible with these people because they're not going to tolerate them. Camouflaging is probably one of the best strategies that you guys can use, and I'm sure you have. Wrapping it in gauze or the pieces of it to prevent their access to it. Running the tubing up the arm and out of the neck of the gown so they have less access to it. Placing the IV as high as you can, but then on the dominant arm, so it's their non-dominant hand that's working to get it off, and they may not be as lucky. People don't think of things like that, though. We just did an activity with the high school students, and we made them use their non-dominant hand to try to indicate, well, this would, if you had a stroke or something like that, and you lost the ability, you might have a hard time. People with Alzheimer's disease have a hard time, too, using their non-dominant hand, so you might be able to use that to your advantage. If you can, I know a lot of times it's just standard issued gowns in hospitals, but if there's any variation there and you can use a long sleeve gown with cuffs, that would be appropriate, or an IV board. You guys know this stuff better than I do, certainly. Okay, so nutrition. Clearly we need to adapt our approach when we're working with Alzheimer's patients to receive adequate food and hydration, since that affects so much of their well-being. We know that good nutrition and hydration are needed to stabilize the illness, so whatever reason they're in for, we can stabilize it sometimes with just good nutrition. If an Alzheimer's patient is coming to you from a home setting, and up until this point they really haven't had supportive services, maybe family really hasn't been fully on board, chances are their nutrition, their status is not where it needs to be, okay? And a lot can improve just by giving them adequate nutrition and hydration. They may have not been getting that before. Excuse me. We know that it's important for wound healing, immune status, lots and lots of other things. So the first thing you need to do is understand the challenges. Some of these are simple challenges. They don't all have to do with dementia. Sometimes people don't eat because they just can't reach the tray. Whoever brought it in left it in an unreachable spot and they can't get to it. Sometimes they can't open up the food packaging. These are really simple things that are, simple fixes. With Alzheimer's disease patients specifically, they have deficits in their sensory processing, so sometimes the food looks unappetizing. Sometimes the food just looks unappetizing. Anyway, sometimes the food, we know the quantities that come in some of these healthcare settings, sometimes it just looks like too much food. And if there's too much food there, it can be overwhelming to the Alzheimer's patient, and all of a sudden they're turned off. They're not going to touch any of it because that's way too much. I can't eat all of that. Okay? People's eating patterns may very well be different. When I worked in the assisted living, you know, there was a lot of talk about this. We've got to get these people to eat. They've got to eat more. Well, how many of you, you know, have a full breakfast, a full lunch, a full dinner, 3 full snacks? Nobody does that, you know? So how different is their pattern at home to what we're trying to enforce on them right now? That may be why they may just not be hungry. You know, we also have to think about these people's activity level is relatively low. They're not doing a whole heck of a lot, and they don't need as many calories as you and I would need just having busy days. They may not be eating because they may be depressed. We've talked about that. Maybe they're used to eating with somebody. They want to eat with somebody, and now there's nobody there in the hospital to eat with. There also may be any number of swallowing problems. In Alzheimer's disease, we see this a little bit further down the road. So we're going to start to see these problems with swallowing pop up. We know that the rate of swallowing slows down with these types of patients. They may forget to swallow, so they may pocket that food in their mouth. I'm sure you guys have all seen people that pocket food. Sometimes they need that verbal support throughout the meal to continue to eat, and then also to do things later in the process to swallow. Sometimes we've got to cue them each bite to actually swallow their food, to take a drink of water, to get the food down, and then to pick up the fork again and repeat the process. If all of those things aren't happening, we've got a problem with nutrition here. So what can you guys do? Obviously, closely monitor their nutrition intake. Can be very difficult sometimes. Lots of different staff coming in and out, but do the best you can. You want to assess the reasons for poor intake. So I just gave you a whole bunch of reasons, but there's a lot of other ones. Do they have, you know, pain? Do they have dentures? Have they lost weight? Their dentures aren't fitting properly? Do they have a sore in their mouth because of that? Do they have dry mouth because one of their medications is causing it and it's making food not taste good anymore? So many different reasons there. You might want to request a dietary consult, always a good thing to do anyway. Partner with the caregiver on food preferences and comfort foods. If they can provide some of the stuff from home, let them do that. Use creative strategies, so small, frequent meals. We've got a lot of dementia patients that won't sit down long enough to finish a meal or even begin a meal sometimes, so finger foods is the best strategy. Sandwiches, granola bars, little things that you can put in their hand and let them wander around while they've got that finger food in their hand. That's a great strategy to use. Sweets. We know that Alzheimer's patients crave sweets many of the time, and that's okay. As long as it's, you know, they're not a diabetic and having these sweets is not really hurting them. If that's the way you get calories in them, if that's what's needed, then that's okay. You also want to think about using facilitation techniques. So mirroring, sitting down, mimicking what they're supposed to be doing helps a lot. Cueing, sometimes hand-over-hand assistance is what needed. Sometimes it's just limiting the choices, simplifying the tray, putting one thing in front of them at a time so there's not all of these things in front of them to make it overwhelming. So lots that you can do in that area, but a really important area because it affects so many other aspects of care. Okay. So in looking at your environment, again, whether it's a hospital setting, probably the craziest of all the environments, or a long-term care setting, a new care residence, whatever it may be, environment is confusing enough, but for somebody that's got Alzheimer's disease, much more so. Remember the progressively lowered stress threshold. That is a tongue twister. I can't say it. Especially in that hospital setting, too much going on for these people on a good day, most likely. So keep that in mind. If possible, avoid placing them in a high traffic area. Now that's not always possible. I mean, you know, you have to do the best that you can to limit some of that. Avoid room changes if possible. I know sometimes in the hospital setting, they're admitted, they come into the ER, they get into a regular room, another problem arises, and they have to go to that specific unit that handles that stuff. As many as few room changes as you can do with this person would be best. Be sensitive to the amount of light. So with an Alzheimer's patient, we know about sundowning. I'm sure all of you guys have experienced it, you've heard it, you know what happens when the sun goes down. If there's a lot of shadows, as the sun's going down, shadows are being displayed on the floor and on the wall in these small hospital type rooms, those can be very daunting figures to people that really can't make sense of the environment and what's going on around them. To keep the lights on, sometimes drawing the shades to eliminate those shadows and things like that is okay. Remove threatening artwork, simple words or pictures. So do you have some, paper like this, maybe it's in a plastic sleeve, where you know you've got a patient that's got dementia, needs to use the bathroom, could basically do it only if she could find the bathroom, right? So we can start, we can make a couple of those to have handy with the word bathroom, put it in a couple directions, maybe use some arrows, but what happens when the Alzheimer's patient can no longer read the word bathroom and make sense of it? Could you put a picture of a toilet? Yes, that might make more sense to that person. So having some of this stuff just handy on the units to know, okay, we've got this person who's really, really confused. Let's get out some of these tools that we can use with them. No, you don't need to use them with every single patient, but if you have some things in your toolbox, it's a good thing. ADLs, we're not going to go through all of these, but just some, each ADL represents its own challenge. Some of them are more challenging than others. These are just some overall considerations. If you can, maintain the home schedule as much as possible. Capitalize on the times when the patient is well rested, feeling good, sort of at their best. Sometimes it doesn't happen in the hospital setting because they're not feeling well, one of the reasons why they're in there. Encourage the patient to do as much as possible without causing stress. So back to that, that adverse reaction slide in the beginning, one of the reasons why they are less likely to return to their previous level of functioning is we get into a hospital and if we're in a rush setting, we do everything for them because we've got to move them on. We need, and I understand there's time constraints, we know that. The more you can allow them to do without stressing them out, that's reasonable for your staffing levels and things like that, you're only helping them by helping them maintain that function. Again, it's the harder way to go, it's more difficult, it takes more time, but it's the better way. Use step-by-step instruction in the ADLs. Remember the 5 C's. So stay calm, stay consistent, be concise, so not a lot of extra words and directions there. Concrete directions, so mean what you say what you mean. None of this jumping in the shower business like I've told people, that wasn't a good thing. And be very clear. Don't rush them. They feel that. They can feel that pace and being rushed. That can cause a behavior. And be aware of other reasons that they may not be participating in their ADLs. Pain, anxiety, embarrassment. Sometimes it's just they don't want a male caregiver taking them to the bathroom, and that's what's causing the behavior. Well, it's not really a behavior. It's a dignity issue that we can try to work around the best that we can. So toileting, obviously lots of challenges with toileting. Perceptual difficulties, so with your Alzheimer's patient, not necessarily true that their eyesight has gone bad overnight, but their brain starts to misinterpret what their eyes are seeing. So maybe they think the toilet's right back there and they can see that and they want to sit down on the toilet, but in fact the toilet is 2 feet over here. Brain has misinterpreted that distance and that can cause a fall. Same would be true for sitting on a chair, getting in and out of bed. I've had a lot of falls in nursing homes where the cause is, well, they missed the bed. Okay, that's the cause, but really what happened is because of their Alzheimer's disease, they saw the bed, their brain just miscalculated that distance and they tried to sit down way too early, 2 feet away from the bed or the chair. Okay, so perceptual difficulties, finding the bathroom, use signs within their ability. So if it's not a word, maybe it's a picture of a toilet, something that they might recognize. Sometimes they try to manage the clothing and they just can't get it all together in time and they end up being incontinent. Sometimes they have a fear of falling, so they don't want to get up and go to the bathroom and now they're incontinent. We don't want that either. Use night lights, implement a toileting schedule, especially in maybe not so much a hospital setting, but in a long-term care setting. That can prevent incontinence, it can prevent falls, and a lot of other adverse reactions as well. Bathing challenges, again, embarrassment, think about the dignity of the person here. Loss of privacy, I certainly wouldn't want somebody all of a sudden having to bathe me since I do it by myself every other day. It can be uncomfortable, it can be the gender of the caregiver. With Alzheimer's patients, many times it's thinking that they don't need a bath. They haven't bathed in 2 or 3 weeks by the time you guys see them, and they still don't think that they need a bath. So that presents its own challenges. We have some nice literature that we can give you just on bathing. It's called Bathing Without a Battle, because bathing can be such a battle with these folks. In your packet, you have a personal care brochure that's going to give you some nice strategies as well. Test the water temperature. They can't always feel water temperature, so if it's too hot, it may not register with them that this is too hot. This could potentially be burning you, or other way, too cold. Avoid splashing them in the face if possible. That can be very frightening. Using a handheld shower head is best for control. You can also give it to them and let them do part of the task, which is what we want. If they have to have a bed bath, try only exposing one body part at a time. Use music, talking, snacks as a distraction as you're doing these activities, so especially a bed bath, because that can be kind of intimidating and uncomfortable. But sometimes to get them to do those things. So can the family member bring in a little CD player with some favorite music on that? Can you play that to get them at least in a good mood, enough to get them a little closer to the bathroom? I've used that many times to get people actually into the shower, whereas before they were refusing. Other thing I used was chocolate, a lot. Chocolate releases endorphins, and we know that. I didn't make that up, that is a fact. So if you can give a person chocolate, it sort of puts them in a happy place for a few minutes, combine it with some music, and they're getting into the shower. They may not, once they're in there, they may not like it, but at least you got them in there. You can kind of hurry up and get this stuff done and make things a little bit better. In fact, one of the very well-known psychiatrists in the Albany area says Tylenol and chocolate, two of the best things. Just pain and chocolate, Grooming, sometimes there's challenges with this. If it's teeth brushing, sometimes they don't want that foreign object in their mouth. They can't understand what the toothbrush is anymore. Lots of times with grooming, and we do the teeth brushing example when we go to care facilities and teach the staff, when you think about it, there are a million steps involved in brushing your teeth. So you've got to pull out your toothbrush, you've got to turn on the water, take the cap off the toothpaste, put the toothpaste on the toothbrush, put the toothbrush in your mouth, do a few movements, rinse it, do it again. Lots of steps, right? We go into a nursing home and we say to these staff members, do this activity. Tell me how many steps are involved in brushing your teeth. I've got staff members that can come up with 3. Then I've got the other extreme where they can come up with like 42 steps. But you've got to find the toothbrush first. It's in the medicine cabinet. You've got to open the medicine cabinet. There's lots of things involved. So if we're telling a person who we think they're still pretty capable, I've seen them brush their teeth before, they should still be able to do this, go on and brush their teeth, and then they don't, it may not be because they don't have the ability, it may be because we need to put some more support there, maybe some more setup for them, because there's too many steps involved. Use a hand-over-hand technique, mirror the motion to trigger the memory. Usually with this grooming stuff, once you get that motion started, whether it's brushing your teeth, shaving, brushing your hair, that's a learned movement, so they can sometimes complete that activity. To get them to open their mouth, you might try saying ah, or yawning. Sometimes that's all we need. They don't want to open their mouth, but if we can do that, we've seized the opportunity there. Use a smaller toothbrush, even a washcloth soaked in some mouthwash to just kind of scrub along if the toothbrush is too daunting for them. So these are all things that's worked. I've tried these things in the care setting, and I've used many of them before. Falls, again, I mentioned this is the largest category of adverse events in hospitals. Over 50% of falls are related to a diagnosis of dementia. So it's not the diagnosis, but it's what happens or what they can't do because of that diagnosis that will cause a fall. There's lots of challenges that lead to falls. Again, unfamiliar environments that have so much to do with all of this. Potential room hazards. So do they have cords and lines and alarms and what's going on? An IV pole. Too many things sometimes that are trip hazards. Sometimes it's lack of or inappropriate placement of assistive devices. So at the very beginning of a hospital stay, there's probably no assistive devices. OT, PT, they haven't been in to evaluate yet, so the person doesn't have what they need. Sometimes when they are in, we've got, maybe the person needs a walker or needs a cane or some other device, but you've got this rapid changing of staff, so the walker may end up over there. Well, that doesn't help them if they need it over here to get up, use it, and get to the bathroom safely. So think about those things. And then a lack of proactive dementia-specific policies and procedures. I don't know many hospitals that have policies that are specific to dementia patients. I know some hospitals that have policies that are around elopement and wandering, but sometimes that's as far as it goes. And there's so many more aspects to care that we really need to, consider differently with this type of patient. So consider maybe some policies and thinking about that stuff. What can you do about falls? Well, a physical therapy evaluation, you want to do that anyway. We're not looking with your Alzheimer's patient to, make them, safer and better in terms of remembering safety strategies and things like that. Probably not going to retain that. Are they doing PT to improve their strength, improve their balance, improve their gait? They can still do that. So it's perfectly appropriate to request a PT evaluation. Maybe a pharmacy consult, lots of meds out there that might cause a person to be a little bit, we're going to go over those. Nutritional evaluation, are they dehydrated? Are they, do they have some deficiencies there that are making them weaker than they need to be? That's a big thing. Family and staff education, okay, so again, if this person gets up all the time, it's perfectly appropriate to say to the family, we want to keep your loved one safe, but we can't do it all by ourselves. Can you sit with them during these high-risk times? And knowing what those high-risk times are is the first step there. Safety technology, again, depending on the response rate, okay? To be sensitive to those things, bed alarms and chair alarms. In a nursing home setting, bed alarms and chair alarms are really sometimes only good enough to tell you that the person has fallen. And sometimes that's because the staff, they become immune to those beeps like we were talking about, so they don't really respond to them as quick as they should. In facilities where they don't utilize those things often, sometimes you have enough time. A chair alarm goes off, somebody quickly races to the alarm, and the person is just, taking a few unsteady steps, and you can get to them in enough time. But in facilities and situations where they're overused, they're not very effective. Supervised ambulation, again, really important for these guys to move, express, to meet those unmet needs, stretching, walking, just the need to move. They might need to do it in a supervised setting to have that be safe and so that they don't fall. And I think lastly, we're going to talk about medication. We know that medication is necessary for lots of people, whether it's you, I, elders, whoever. But we know that sometimes it can be overused. In terms of, behavioral challenges that we see with the Alzheimer's patient, you want to use medication as a last resort to control those behaviors. Now, I was in that setting. I did this care for 15 years, so there was many times over those 15 years that medication was needed. We tried the approaches. We tried to communicate a little bit better. We tried these wacky behavioral interventions, and nothing worked, and the resident was really becoming sort of a danger. And to get them over that hump there until these behaviors kind of resolved, we had to use some medication. So there's room for medication as well, but it shouldn't be overused, and it should be used as a last resort after you've tried these things, these strategies that we talked about today. We know that it presents challenges, so an abrupt change in mental status because of some of these medications, sometimes weight loss, sometimes a bad taste in your mouth that doesn't make you want to eat, dry mouth. Sometimes they cause agitation, restlessness, urinary retention, sometimes a decline in functional status. Sometimes they make the person really sleepy during the day, and we don't want that either. So each med needs to be really thoroughly evaluated, not only for its individual effect on the resident, but also how is that medication interacting with the other slew of medications that the resident or the patient might be taking. This is just a short list of medications that cause an acute change in mental status. So obviously drugs to help you sleep, narcotics, muscle relaxants, seizure medications, Parkinson meds, corticosteroids, theophylline, cardiovascular drugs, antimicrobials, geropsychiatric drugs. Lots of drugs can cause acute mental status changes. So we have to use these with caution, use them when they're appropriate. I said that the bulk of the time is spent in the moderate stage of a classic Alzheimer's patient, and that's very true. And that's when we see these behaviors. Usually the behaviors don't last into the late stage of the disease. So they usually will fizzle out and sort of resolve on their own. So sometimes you just need a medication to sort of get over that bad hump with the resident until these behaviors are looking like they sort of resolve on their own. If they're not that bad, just keep that end in mind, knowing it might not always be like this. We can try some interventions, and hopefully these behaviors will go away at some point. So Lots of challenges associated with medications, other challenges as well. So just in summary, as nurses, you need to be prepared to adapt the normal hospital procedure, so the stuff that we do every single day, and make it work for your patients with dementia in the hopes of providing better care and ultimately better outcomes for them, because that's why we're all doing this. Very, very important to include the family and learn what worked at home and get them to assist. Include them in the caregiving process. Think of yourself as care partners, really. We're lots of different care partners for one person who may be in the hospital at that moment, but care comes from lots of different areas. Family members, hospital staff, pastoral staff, volunteers. There's so many components to it. Use all of those resources. And remember always that the person is more important than the task. Now I say that to nurses who know that if the task is more important because it's a real serious medical issue or a safety issue, of course the task is more important. But when it comes to caring for Alzheimer's patients, they are more important overall than the task. If it's not going so well and you can walk away and go back to it, or walk away, try a different strategy later, that's what you need to do to provide the best possible care for these unique patients. And the last thing, and one of the most important things that you guys can do in the healthcare field, is to give your caregivers resources. So obviously we're talking about Alzheimer's disease and dementia today. The Alzheimer's Association, just because of the nature of the illnesses that we're talking about, should always be used as a resource, not only for your family members, but for you as staff out on the floors there as well. We have a 24-hour-a-day, 7-day-a-week helpline. So if you've got a dementia patient that's maybe the 11 to 7 shift, it's 2 o'clock in the morning and they're exhibiting some really kind of strange behaviors, you've tried a couple things, you just don't know where to turn next, as long as the situation is kind of at hand, it's not a danger, give the 800 number a call. There's a person on the other end of the phone that can walk you through some strategies to help you with these behaviors. Now in addition to that, in your folder you guys also have this purple brochure. On the back is that 800 number. If you open it up, there's a whole list of services that the Alzheimer's Association provides. And a lot of people are unaware of these services. Most of them are free. We offer information and referral. So if you need, you're working with a family and you need to know what is the nearest adult daycare facility that takes people with Alzheimer's disease in Glens Falls, we have an answer to that question. If you need an elder law attorney, if you need somebody to help them set up Medicaid, we've got answers. So we don't, charge for that service. Give us a call. We can shoot you out some resources. We also offer care consultations. So again, behavioral challenges, we can strategize. We can help you with that. Sometimes you guys get family members and you say, you know what? We're going to take them home after this hospitalization for a little bit, but we can't manage them. What do we do? Well, you guys as nurses being on the floor probably don't have time to sit with them and say, okay, well, here's all of your options. Let's talk about this for a good long time. We've got the time to do that, so have them call us. We can walk through the options, what's available in the area. That's why we have people all over doing this stuff. We have over 40 support groups running in the 17 counties that we serve. You guys see family caregivers that are probably really stressed out. They're caring for an Alzheimer's patient. We also see staff members that are really stressed out because they care for a lot of Alzheimer's patients. Anybody can attend these support groups. Not only is it just a supportive environment, it's also an environment where you can learn from others. You've got a family in there that says, you know what, my mom's beyond that now, but we had that same problem. This is what we tried and it worked. It's a great learning experience as well. Lots of education programs, so we do stuff like this. We do things, I was mentioning that Kim and I were in the high schools yesterday teaching the 9th and 10th graders about Alzheimer's disease and doing some really fun activities with them. We go to libraries, senior centers, right into the hospital to train the staff on the floor. Wherever we're needed, we want to share awareness and knowledge about this disease because we want these people to be cared for appropriately. And then safety services, I mentioned the Medical Alert Safe Return. We've got some other web-based tracking devices that might be beneficial. So use us, call us. We certainly will help you in any way that we can. And the last thing here that we have, we talked a little bit about clinical trials. So again, leave those cards behind if you have it. We also have this little postcard in your packet. Many of the other diseases, and there's not one disease that's worse than another one. They're all not good. But many of the other diseases, their prevalence is kind of shrinking because money has added a lot of funding for HIV and AIDS research, for example. HIV and AIDS has gone like this because of that research. If you want to fill out this postcard and leave it behind, our mission here is to tell Congress more money needs to go into Alzheimer's research because we've got to put an end to this disease. This disease alone really has the capacity to bankrupt the healthcare system, especially because baby boomers, they're going to come sort of age all at once, and we're not going to be able to care for them. So we really need to do something about it. If you care to, fill that out, leave it behind. We will send that in for you just to tell members of Congress to act on this and help us with the cause. So I've talked a lot and enough, but that's nothing new. Any questions about any of this?
I don't have a question. I just what my experience with my mother was, which was hard for me, is my mother growing up wasn't warm or fuzzy or didn't like the people that were the kind of earthy kind. But as she got into this process, she was more gravitated, and for me it was very hard. I had to realize that, because I used to say my real mother wouldn't have tolerated this, and it was hard to realize that she was different, my mother, but she was different.
Yeah. So
And
we
I
see
think
these.
that's hard for people to see, that
It is.
they are a little different.
They
They
are.
change, they're different. And like I said, I would, if somebody would come in and do something or call her a name that used to put her right over the edge, you know.
Yeah.
She was, like you said, wanted respect or wanted a certain name, and her name was Josephine, but you never called her that, or anything, but somebody would call her Josie. She would, before, correct her right away,
Yeah.
and not nice. But as she got into that, she would like
Yeah.
respond more to that, and I'd be like,
It's
God.
interesting, yeah. So we see those personality changes. Sometimes they're not good personality changes. So we might see the nice person become kind of angry and mean. Sometimes it goes the other way, and it's kind of, a better personality change. So we see them, both sides of the spectrum
Yeah,
there.
that's hard for families to see.
It is.
To,
Yeah.
Just a quick question. What is how young is the youngest patient that you had? Almost 50.
Yep.
And the other is, the data shows that, I think that's for the age of 65. What is, how many patients are misdiagnosed?
I don't have a number in terms of misdiagnosis. I would suspect it is a good number. It's a good number of people. We're still at the point where we can't be 100% sure that it is Alzheimer's disease until autopsy. But thankfully, we've come a really long way in the area of diagnostics. And around here, we've got very good diagnostic skills, and we can be up to 97% sure that it's Alzheimer's disease. But sometimes we still don't know until we see how this progresses. Years later, well, it was looking like it wasn't quite, or it was looking like it's a little something different. Now it's looking more like Alzheimer's disease, and that Robin Williams case is kind of the prime example of that. Looking like Parkinson's at the beginning, we never really got to the Lewy body diagnosis before he died. But that's what it was, you know what I mean? So sometimes we don't get an accurate diagnosis until we see how this progresses. So there is misdiagnosis, but it's much better. And in terms of the youngest person in our office, the youngest person that we have helped was 39. So it's really scary,
How much of a familial does it run in families?
Yeah.
Do you find that it is, or is it just something that's just kind of random?
So there's a little bit of a genetic connection. In very simple terms, what we say is if you have a first-degree family member, so mother, father, sister, brother, first-degree family member, who developed Alzheimer's disease later in life, and by that I mean, late 70s, 80s, when we see true Alzheimer's, your risk is only slightly higher than a person who does not have that first-degree family member. Where we see the risk go up is if you have more than one, so maybe a mother and a sister, that have it, even if they developed it later in life, that makes your risk go up. And then also, if any of those first-degree family members developed it earlier in life, so under the age of 65, which we would consider early onset, or younger onset Alzheimer's, that makes a person's risk go up pretty significantly. So there are some genes involved. The genes that are involved with just regular Alzheimer's disease that we see in the 70 and 80-year-old patient, the gene is a non-deterministic gene, meaning you and I might have this gene. It doesn't determine definitively whether you will develop Alzheimer's. All it says is if we have it, Now your likelihood is a little bit higher, but you still might not get it. So.
Can I just ask a question? I have a friend who is in an assisted living facility on another floor, and every time I go in, she's sleeping.
Yep.
Is that, and when I ask her why is she sleeping, she's like, what else am I supposed to do?
Yeah.
So, is that normal?
It is normal. You know, as people progress into their Alzheimer's disease, they sleep more. And once a person gets into the late stages, it's not uncommon for 18, 19, 20 hours a day of sleeping. That would be normal, okay? Sometimes there's multiple factors. So they're progressing, they're going to be sleeping more, but they can't self-initiate activities. So if there's not staff there initiating activities for them, they're going to go to sleep. Sometimes they have some depression that's gone undiagnosed and they don't have that motivation. They don't really feel that good. So that's another reason. There's a lot of reasons.
It's hard to even figure out what kind of activities to do or.
Yeah, I'd imagine that the staff, it's not a one-stop shop, you know what I mean? It's not a cookie cutter, okay, this person has Alzheimer's disease, therefore we do these activities. It's really person-centered stuff. You know, you have to know what they like to do, what's meaningful to them. When I worked in the assisted living facility, we had this beautiful renovated kitchen, and so on Tuesdays I would say, okay, today's the day, we're going to be baking in our brand new kitchen, everything is fantastic. So if I said to the residents, let's go guys, come on, it's Tuesday, we're baking today. No, I don't want to go. Oh, my leg hurts. Oh, every excuse in the book. I'd have nobody. But then if I said to them, you know what guys, the Children's Hospital down the road called, they're doing a fundraiser, a bake sale, because they want new playground equipment for the children. They're counting on us. Can you guys come with me and bake? I'd have the whole floor with me because I sort of inserted the meaning into the activity. Sometimes the activity is okay that they're choosing to do, at the assisted living, but the meaning isn't there. You know what I mean? And we all need that meaning and purpose. All of us, all of them. If it's not there, why bother? You know what I mean? So lots of different things to look at in activity world. Other questions or? Well, I thank you guys very much. I hope you got something out of this program and can take the information back to your care facilities and yeah, thank you.
So, have the foundation and Nursing Alumni Group here's a little token of our thanks
Thank
for
you
your
so
time
much.
and
I
expertise.
appreciate that.
I know I
Thank you.
learned a lot. I'm not in healthcare, so I can only imagine for those of you who are actually dealing with this a lot more. It was really wonderful. I appreciate it.
Absolutely.
I just wanted to say, too, that this fall, for the first time, the Nursing Alumni Group got together, several donations, and we actually gave a scholarship to a student this fall called the Nursing Alumni Scholarship. We have several alumni scholarships, but if you did want to help out in that endeavor, Rachel in the back right there might have some envelopes up here. We take checks. You can go online and just make sure there's a memo that says Nursing Alumni Scholarship. As Sarah mentioned earlier, you can stay connected with us on our website. We're on Facebook under there's an alumni association we share posts, and there's one specific to nursing alumni that Catherine actually created. We would love to stay in contact with you, have you join us for as many of these events as you can in some of our planning meetings. We love your ideas. I've loved working with our nursing alumni. Thank you.
Hey, you work at Glens Falls Hospital, it does count toward your levels. I did check that with
And if when you leave, you have a parking ticket on your car, please send it to the foundation. We'll take care of it, but hopefully everybody's okay. But thank you for coming. We really appreciate it.